Okay, so we are now recording and admitting everyone in from the waiting room. Hi, everybody, welcome. We are just getting started now. We're letting y'all in from the waiting room. Today our speaker is Dr. Kanter, and he's in an unusual spot, so he actually does not have a video today. So we won't be seeing him, we'll just be hearing him. And I do have all of our participants are muted and your cameras are turned off. It's only for security issues, so I'm sorry about that. And we do want all of your questions, so please write them in the chat feature, which should be in the lower right of your screen. And so during the webinar, please post your questions. We will take them all at the end.
All right, hello everyone. Thank you for joining us for our ongoing COVID-19 webinar series. We are grateful today to be hearing from Dr. Joseph Kanter, who is the Assistant State Health Officer at the Louisiana Department of Health, and he is also our Clinical Assistant Professor in the Department of Medicine section of Emergency Medicine. As Sam mentioned, we will be taking questions, so don't forget you can post those at any time and we will get to them at the end. If there are a lot of questions, we'll make time to go a little bit longer if time permits and try to get through them as best we can. So without further ado, Dr. Kanter, welcome. We're grateful to have you with us.
Well, thank you for that kind introduction. I appreciate it. It really is a pleasure and an honor to be able to be here for a short time this afternoon to be able to chat. I want to apologize off the bat. I'm catching me between a couple of meetings I couldn't avoid. So I'll be talking to you from a non-traditional location. And if you hear some background noise, I do apologize for that. I'll try and go to a better spot if that happens. What I'd like to do is spend a few minutes reviewing where we are in the outbreak, both in the New Orleans region and for the state. Talk about the trends that we've seen up until this point, and talk about what will be the game plan going forward. And the governor made a big announcement of this yesterday. And talk about some of the pitfalls and some of the unanswered questions that remain. And I think I'll talk for about 10 or 15 minutes and be sure to leave plenty of time for conversation and questions and answers afterwards. So today we are looking at 51 days of our outbreak in Louisiana. The first case we had was an individual who was hospitalized in UMC in Orleans Parish. A gentleman actually resided in Jefferson Parish, and that was May 9th. The 51 days have surpassed since that point. The first 2 weeks of our outbreak in Louisiana had the sharpest rate of increase of anywhere in the world, to our understanding. Because of this, you saw a very aggressive implementation of social distancing measures. To be frank, we're quite blessed with really good leadership from the governor's office on down to the parishes, particularly here in Region 1. The mayor, parish president, governor have all been just extraordinary in heeding the advice of experts in the room. And the social distancing measures and the stay-at-home orders that you saw come down are an example of that, and they came down quickly. And because of that, we're in a better spot than we had feared we would be. And I'll go into that a little bit more. So today, in total, there are just over 27,000 cases of COVID in Louisiana, of which 48% are in what we refer to as Region 1, which is the greater New Orleans region, encompassing Orleans, Jefferson, Plaquemines, and St. Bernard parishes. We've had 1,697 deaths, of which 45% are in Region 1. At this point, there are 1,666 individuals currently in a hospital bed across the state with COVID, of which just shy of 15% are on a ventilator. That number of 15% has gone down significantly. Last week, it was around just over 21%. A week or two before that, it was around 32%. So ICU teams, particularly in Region 1, have just been extraordinary in keeping people off vents, first of all, using non-invasive mechanisms like BiPAP when appropriate. And when patients do get intubated, getting them off vents quickly and safely. They're actually, I'll tell you, doing nation-leading work right now. And there'll be some data that comes out of this at some point in the near future. But for context, a large hospital system in New York City, 12 hospital system, announced last week that their mortality of vented patients was 88%. Informally, colleagues in Seattle have told us that they're seeing closer to 90% fatality of vented patients. And we don't believe we're seeing numbers anywhere close to that here, really because of the work being done in our ICUs. So expect more to be written about that as we go forward. If you had looked at our sharp trajectory a few weeks ago, it would have put us in a position now that we were well exceeding the hospital capacity of the region, availability of ICU beds, and availability of ventilators. To that end, there was a large effort to increase the acute care capacity of the state, but particularly this region. You see a very large field hospital that was constructed in the Memorial Convention Center downtown that was initially scoped out to be 3,000 beds. You saw hospitals being very creative in how they expand capacity within their four walls, sometimes building whole new ICU units, turning numbers of rooms into negative pressure rooms, being very creative from an engineering standpoint with their HVAC systems. And you saw an increase in the number of ventilators that were brought into service here. And thankfully, because of the stay-at-home orders and the social distancing that came from our elected officials, but really were followed and by the community. The community had to buy into these for it to be effective. We have bent the curve, so to say. We were looking at a spike in cases right now that would have clearly overwhelmed the healthcare system and created a situation where people could not get care for any number of conditions. And we averted that because the curve was flat. Our R0, or the number of individuals that one COVID patient infects, went from somewhere around 2 to 3, or even 3.1, 3.2, down to below 1.3 in this region, which is really remarkable. It allowed us to avert that spike. So right now we're plateauing. We're plateauing the number of cases here, maybe even a little bit decrease in the New Orleans region, but it's a high plateau. We're quote unquote a high burden state, and that remains a lot of COVID still in the community and a lot of risk still in the community. Of the 27,000 cases of COVID that we know were diagnosed, of course, that's widely understood to be an undercount because a lot of people have asymptomatic infection and a lot of people have mildly symptomatic infection and never get tested. But of those 27,000, we project 17,000 have recovered. That leaves 10,000 with active COVID remaining in the state. So still a very high burden of disease and still a lot of reason to take precaution and to go slow. That's the data that guided the governor's decision yesterday. Now, one of the defining characteristics of our outbreak in Louisiana, which is characteristic of across the country, is the large degree of racial disparities that we're seeing, both in terms of fatalities and we believe, although the data is less clear, in cases. So I can tell you, statewide, 58% of fatalities are in African Americans, although they represent only 32% of the population. Here in this region, Orleans Parish, 76% of fatalities are in African Americans, although they represent 59% of the population. And even starker in Jefferson Parish, 54% of the fatalities are African American, yet representing only 28% of the population. We know of two reasons why this is. There is likely to be others that we'll find out. Number one is we know that the share of comorbid conditions is larger in marginalized communities, and folks have worse clinical outcomes when they do get sick. The more COVID conditions they have, diabetes, hypertension, renal disease, and obesity in particular. Second is the degree of exposure risk that marginalized communities have. And we recognize that being able to work from home, use Zoom, those are privileges that not everyone has. And someone who has a job as a grocery clerk or a bus driver, for example, doesn't have that ability. And so the exposure risk to folks is not equal. And that goes for isolation ability at home. So if a family member gets sick and is at home, how well is that family able to use the space in their house to isolate themselves from that individual? That answer differs very based on socioeconomic status. So we think that vulnerable individuals are vulnerable now and really in every emergency that we see. And, we've worked hard to try and address that. There's a lot of work to do, but it's going to be a charge for all of us going forward to address this outbreak in cognition of the really stark disparities that exist. So going forward, the governor announced yesterday that his assessment, which we agree with, is that the state is not ready to move to beginning the reopening process, but we hope that will be different come May 15th. We're using the White House's framework on this, and they really did produce a decent framework. They enumerate 3 measures that we would like to see met before reopening commences. We're looking at what we refer to as COVID-like illness, which is similar to influenza-like illness, and that's judged based on a network of sentinel surveillance sites throughout the state. We're looking at the number of new diagnosed cases of COVID, and we're looking at the number of new hospitalizations. We'd like to see all 3 of those decreasing over a 14-day period before we begin the reopening phase. Happy to say that they are decreasing in the Region 1 area, in the greater New Orleans area. That's not the case for every part of the state. So, for example, new diagnosed cases continue to increase in Region 2, the Baton Rouge area, Region 4, Lafayette, and Region 8, the Monroe area. They're plateauing in Region 9, the North Shore. And the number of hospitalizations continues to increase in Baton Rouge area, in the Monroe area, and it's plateauing in the Shreveport area. We would like to see all of those decreasing before we move into phase 1 of reopening. But we have reason to believe that these other regions will be there come May 15th. There's a few guiding principles that we're going to use as we plan out the reopening process. Number 1 is the health sector will be a priority. If any industry is going to come back first, we'd like it to be the health sector. Beginning now with a relaxation of the restriction of elective procedures, now including time-sensitive procedures, and looking to fully relax that in the near future, bring office visits back online, bring the healthcare sector back online fully. The second guiding principle is we'll need adequate testing capacity. We're estimating we need to be able to test about 4 to 5% of the state's population every month to be able to have enough surveillance on when cases increase, should they do so. At the moment, we're just over 3% statewide. We need adequate contact tracing capacity. We need the ability as a health department to link up with newly diagnosed cases, identify their close contacts, and reach out to those close contacts and advise quarantine very quickly. And we'll measure this by having the capacity to interview new cases, 100% of new cases within 24 hours of diagnosis, and interview 75% of those contacts within 24 hours. We're not there yet, but we're getting there, and we certainly will be there by May 15th. The fourth principle is we need enough personal protective equipment, or PPE, in hospitals, in clinics, and for first responders, for folks to be able to go about their jobs safely. And the final guiding principle is we have to go about this in a way that doesn't exacerbate the racial inequities that we already know exist, particularly with the COVID outbreak. So that's a framework of what reopening will look like. If all goes to plan, then on May 11th, the governor will announce that we'll move to phase 1 on May 15th. Details are still being ironed out to some degree, but we can look to lifting the stay-at-home order. We can look at some restaurants and some large churches being able to reopen, albeit with a much less capacity. We're looking at 25% of their occupancy as rated by the fire marshal. Some personal service outlets like barbershops and salons being able to open with precautions, like they won't be able to have people congregate in the waiting areas, and some outdoor recreation areas opening as well. Important things to note is as we move forward to reopening, things are not going to look the same, and folks are going to be asked to take precautions. Folks are going to be asked to wear masks anytime they go in a public building, for example. And businesses, if they are allowed to reopen, they're going to be asked to do so in a safe way, to provide masks for their staff, to create the ability for customers to appropriately distance themselves, minimum of 6 feet, while they are inside. So it's going to take a lot of buy-in from folks really across the economy, but we think that's the only way that's appropriate and safe to do this. And the other aspect is we'll be watching the metrics very closely. And this is all with the understanding that should cases or sentinel surveillance or hospitalizations begin to increase in a statewide or a particular region, we might need to hit pause on the reopening and go back to some restrictions until we figure it out. But I think we're all looking forward to moving into the next phase. Just understand that it will be done in a responsible and a safe way. As I'm sure has been discussed in this series, there's just a lot of questions that still remain on COVID as an illness and as an outbreak. It's still so new, and we're literally building this plane as we fly it, and new information comes available every day. To review some of the key remaining unanswered questions, the duration of viral shedding remains unanswered. How long an individual who's positive continues to test positive. We've seen accounts of people testing positive upwards of 28 or even 30 days from the point of diagnosis. And the degree to which that viral shedding is actually infectious, or is it just dead viral material that can get picked up on a PCR test? We don't know that answer yet. The degree to which serology tests, antibody tests, will be helpful in this remains an outstanding question. These tests have a lot of unanswered questions. They are not terribly specific, and that the specificity is less than the prevalence of disease in that community. So, for example, some of these antibody tests have a specificity of 95%. If you're looking at a 4% prevalence, or excuse me, a 6 or 7% prevalence in your community, you're in a situation where an individual is actually more likely to have a false positive test than they are to be accurately diagnosed with it. A lot of these tests have cross-reactivity to the other strands of coronavirus. All of those remain outstanding questions. And what do we even do with the results? Does a positive IgG, for example, actually mean that that individual is immune? Those are still outstanding questions that we hope to get answers to. Effective therapeutics are an outstanding question. A lot has been talked about hydroxychloroquine. It doesn't look like it's living up to the promise. Remdesivir remains investigatory. There are other therapies that are being investigated. We still don't have good answers on what therapeutics might be effective. What is not an outstanding question, though, at this point, is that asymptomatic infection is not only possible, it's quite common, and it's likely a driver in the spread. And as we develop testing strategies going forward, I think you're going to see testing of asymptomatic individuals, particularly in high-risk settings, congregate settings like homeless shelter, for example, to be a larger component than it has been in the past. It's been a very fast-moving ordeal. I think you see every state approaching it differently. I can tell you this governor is data-driven. He gives a lot of deference to medical and public health experts, and he's going to follow the data going forward. I can tell you I'm fairly thankful that that's his approach. We will need partnership in the health community going forward on a number of levels. We're going to need the health community to help reinforce guidelines and best practices to their patients and to their respective circles. Things like wearing a mask when you're in public, maintaining distancing, being vigilant. We're going to need help reinforcing that message. We're also going to need help communicating back to us in the Office of Public Health what is and is not working. As we slowly reopen, we're doing the best we can to track measures and look at the data, but that's limited to what gets reported out. And so as folks are on the ground in the community, in hospitals and clinics or in their own circles, as they're seeing things that might paint a particular story, I would ask that folks communicate that back to us so that we know, because there really isn't a blueprint for this. We're literally making it up as we go along. It's an educated endeavor, and we're looking at best practices, but there's not a definitive playbook for this. So we're going to ask for folks' help in communicating back to us what they feel is effective and not effective. But we think we're in a good place. We're particularly in a much better place here in the New Orleans region than we had feared we would be. And that's really to everyone's credit, medical community, public health community, and everyone at home who's kind of been responsible. We think we've really been a model region for how a quick response to a fast-moving outbreak can be done. So it's been about 18 minutes. I'll stop here and look forward to having a conversation for 15 minutes if I can.
Well, thank you so much, Dr. Kanter. And that was really wonderful information and certainly a lot to process. I know for me, I have felt this is an unprecedented situation and so much information all coming at once. But one of the things that, I've heard a lot about is contact tracing and how some states are really utilizing that to slow the spread. Is Louisiana looking at that as a effective way of slowing the spread here in our state?
Absolutely. It's really going to be a cornerstone of the reopening strategy. The contact tracers are a tool that we in the Office of Public Health have used for decades and decades. We have a team of about 30 full-time that work in the Office of Public Health, and they deal with a number of infectious disease, measles, syphilis, you name it. During this outbreak, we have surged that to about 70 or 80 individuals, but going forward as we reopen, that's going to surge on a scale that we have never seen in public health before. So we're looking at scaling up to somewhere between 400 and 700 contact tracers for the state of Louisiana. It's going to be a massive undertaking, and our goals that we're setting for ourselves are ambitious, and we want to be able to interview new diagnosed cases, 100% of them within 24 hours, and 75% of their contacts within 24 hours. That's a very ambitious goal that we hope to be able to meet. So right now, work is ongoing to contract with a number of different agencies that we can partner with to increase testing capacity. We're bringing online a fairly sophisticated IT platform that will allow us to track and route these type of tracing cases. And again, this is an expansion of the public health infrastructure on a scale that really has never been seen in this short of time. So we plan to have it in place by May 15th, and it really is just an unprecedented undertaking. But it will be a very important factor going forward, because you can imagine there'll be new cases and small clusters that pop up as we reopen, and the degree that we're successful is going to be relative to the degree that we're able to identify quickly those clusters, contact trace, and get everyone isolated and quarantined quickly before those clusters become small outbreaks of their own.
Right, so that helps us to remain open as we have a powerful mechanism to do the contact tracing.
Right, absolutely. I mean, we feel more comfortable with businesses reopening if we know that new cases will be identified quickly and be contact traced and those contacts quarantined. That's the only way that reopening will be able to proceed safely.
We do have a question about contacts. Someone asked, how will contacts be defined?
So we define close contacts as somebody who was within 6 feet of an individual for 15 minutes or longer for going back likely 1 to 2 days prior to that individual developing symptoms. And that time period has been a moving target, because earlier in the outbreak, when we didn't know as much about asymptomatic transmission, contact tracing was going back towards really just the time of symptom development. with the amount that we know now about asymptomatic, it's going back earlier, and the CDC is still providing guidance about how earlier that is, but 1 to 2 days prior to development of symptoms is a safe bet.
Okay. The first question we had was, Dr. Stein is asking, if a prior infection with SARS-CoV-19 does not confer immunity, then how would a vaccine work?
Thanks, Dr. Stein. It's a great question. We don't know that it doesn't confer immunity. We just don't have evidence yet to say that it does. And the NIH and Dr. Tony Fauci has talked about this a lot. If the disease acts like other coronaviruses, we would expect some degree of immunity to be conferred. But we have to show that in the data, and it's not yet been shown really because it's such a new disease. If it does confer immunity, then it opens up to scenarios where individuals who have antibodies, have IgG, for example, would be able to perhaps come back to certain professions quicker. But before that type of schematic would be able to put in place, we really need to see data that shows that exposure and prior infection really does confer immunity, and that data just isn't there yet.
Okay. We have a question. Do you think that we will be asked to daily get tested for our temperature for any establishment we want to enter?
I think it's going to depend on the nature of the work. I think for folks that work in the hospital or clinic, yes, I think that likely would be a mitigating measure that we would look to say this is a safe way to do it. For folks that work in an office building or other professions, likely not. And we might need to change that based on how the early experience goes. But for now, for people that work in hospitals, it's fairly routine to check temperature upon entering the building, and we think that's been effective. So I would like to see that continue at least through the first phase of this.
Okay. Someone's asking about what about requiring people to wipe down surfaces? Like if people are starting to attend church or sit on park benches, it says, I haven't heard much about being addressed about concern of virus living on surfaces.
Yes, absolutely. And, the data, there's been a couple studies out there that show the viability of the virus on various surfaces, and it can live on hard surfaces, plastic and metal, for quite some time, hours or even a couple of days. So it is, fomite exposure is a part of transmission here, and it certainly needs to be addressed. And that will be a part of the governor's order as he lays out a framework for reopening. Mm-hmm. That for a business or restaurant, for example, to reopen, one of the precautions they're going to be expected to take is to be able to wipe down hard surfaces with a disinfectant at certain intervals. Don't know the specifics yet of what that would look like, but that will surely be a component. It will absolutely be a component, for example, of if a church is able to reopen, and it absolutely will be a component of schools, daycares, and camps, if and when they are allowed to reopen.
Right. So in your role, what are you seeing right now that gives you the most hope about Louisiana and the people living here?
That's a great question. Thank you for that. It's been a lot of bad news. I'm happy to answer a happy question. I think people have come together and heeded best practice and evidence in Louisiana in a way that few states have. Again, we, particularly in the New Orleans area, had an incredibly fast rise to our outbreak. And, we were projecting really scary scenarios. ICU level patients of the magnitude 2 to 3 times the current capacity of our ICUs here. 2 to 3 times as many patients requiring a ventilator as would have been available. Just terrifying projections that no one ever wants to see. And that was communicated to the public. And again, I think our elected officials just did a textbook job here. I really do. Up and down the line, I really couldn't be prouder of them. But the public listened. I think the public recognized the uniqueness of this situation. This is once in a generation, if that, event. I mean, there's really no comparison here except going back to yellow fever. I think the public recognized that. I think the public made really difficult sacrifices. I mean, staying at home is the least of it. I mean, think about families that can't be at their loved one's side in the hospital as they're sick or in the ICU, families that can't hold the type of funeral they would like to for loved ones who pass, just unspeakable sacrifices. And I think by and large, people understood the need and did it. And it's because of that that we're in the position now that we're even able to be discussing reopening. And I feel fortunate for our community for doing that. It's I think as a public health professional, it really makes me proud that we were able to meet a challenge like this.
That is really great to hear. Thank you for sharing that. I think we can wrap up unless anyone else has any more questions. I do want to let everyone know that this has been recorded. It's actually on Facebook Live. The LSU Health Foundation will also be on our website, and that is at lsuhealthfoundation.org/coronavirus. So this will be there, and you can also see, we did just get one more question, but you will also be able to see any upcoming webinars. We do have one next week, next Wednesday, and we'll actually be discussing medical training during this time, which will be something interesting. So we did have one more question. The rate of positivity in prison populations and those that are COVID positive symptomatic.
Good question. Really difficult area and a big area of concern. I won't even venture to say a rate of positivity because I think there's a lot of undiagnosed infection in prison populations. It's a challenging environment. Providing quality medical care in a prison setting is challenging in its own right. Being able to properly isolate and quarantine in that type of setting is really hard. We know it's a big area of concern. At the moment, we've worked hard to supply jails and prisons with enough tests to be able to do the amount of testing that they need. I do worry that there's undercounting or at least under-testing happening in incarcerated settings. I also worry about how quickly sick patients there get identified and transported out to hospitals. This is a challenging, particularly challenging in prisons. I think going forward, the more testing that happens, the more visibility we'll have, and I think the data will come out, and prisons and jails will act appropriately. It's just a hard environment, but a lot of attention being paid to it right now. It starts with increasing the amount of testing.
Thank you so much again, Dr. Kanter. We know how busy you are, and we appreciate everything that you are doing to help us enter phase one and move onward in this pandemic. Again, thank you so much. Thank you, everyone, for tuning in. Please do join us Wednesday. We will be hearing from our medical residents, and they're going to talk to us about their medical training during this time, so that will be another interesting topic to tune in for. Thank you all, and please stay safe, and we'll see you next week. Thanks again, Dr. Kanter.
Thank you. My pleasure.